Treatment options for persistent asthma. Asthma is a chronic inflammatory disorder of the airways, characterized by three components: inflammation of the airway, bronchial hyperresponsiveness, and obstruction to airflow. Allergens trigger asthma by becoming lodged in the respiratory mucosa upon inhalation and provoking the expression of IgE. IgE is an allergic antibody that is involved in the pathogenesis of many allergic diseases. IgE interacts with mast cells, eosinophils, leukotrienes, histamines, and prostaglandins. These inflammatory mediators precipitate the inflammatory cascade, which then causes the airway hyperresponsiveness that's associated with asthma. Here are a list of common asthma triggers. Common allergens that precipitate asthma attacks include strong odors, chalk dust, animal saliva, house dust mites, cockroaches, mold, and seasonal pollens. Other asthma triggers include exercise, upper respiratory infections, rhinitis, sinusitis, post-nasal drip aspiration, GERD, changes in the weather, cold air, stress, and tobacco smoke. Here's a picture that demonstrates the anatomy of an asthma attack. You can see the difference in inflammation of the normal airway versus the obstructed airway seen in an asthma attack. Spirometry is essential in diagnosing asthma in children who are 5 years of age and older, as well as adults. Medical history and physical exam are not reliable means of excluding other diagnoses or assessing lung status. Spirometry should be done before and after the administration of a short-acting bronchodilator to assess the presence and extent of airflow obstruction and whether it is immediately reversible. Airflow obstruction is indicated by a reduced FEV1 over FVC ratio. There are 4 components of asthma care. Number 1, assessing and monitoring asthma severity and control. Number 2, education for a partnership in care. Number 3, control of environmental factors and comorbid conditions that affect asthma. And number 4, medications. In regards to assessing and monitoring asthma severity and control, we need to look at impairment and risk. Impairment refers to the frequency and intensity of symptoms and functional limitations the patient is currently experiencing or has experienced. Risk refers to the likelihood of either asthma exacerbations, progressive decline in lung function, reduced lung growth in children, or risk of adverse effects of medication. Education for a partnership in care. Patients need to be educated about their condition as well as taking their medications correctly, identifying and avoiding environmental exposures that worsen the patient's asthma, self-monitoring, using a written asthma action plan, and seeking appropriate medical care when necessary. Control of environmental factors and comorbid conditions that affect asthma. Patients need to be aware of allergens, irritants, infectious or dietary factors that might exacerbate their asthma symptoms, as well as how comorbid conditions can affect their asthma condition. This chart is what we look at to determine asthma classification. As you can see, classification of someone's asthma would be considered mild intermittent if they have symptoms less than or equal to 2 times a week. Mild persistent asthma is when symptoms occur more than 2 times a week, but not every single day of the week. Moderate persistent asthma is when someone has symptoms on a daily basis. and severe persistent asthma is continuous symptoms, frequent exacerbations, and frequent symptoms at night. You can read the rest of this chart and refer back to it to further classify and be sure you're finding the correct level of severity of your patient's asthma. Depending on this chart is what we use to look at the treatment of your patient's asthma. For mild intermittent or exercise-induced asthma, no daily medication is needed. However, a short-acting beta-2 agonist, as needed, should be prescribed for your patient. For mild persistent asthma, the preferred treatment is a low-dose inhaled corticosteroid, as well as a short-acting beta-2 agonist, as needed for acute exacerbations. You can see listed the alternate regimen suggestions if for some reason the low-dose inhaled corticosteroid is not a good choice. For moderate persistent asthma, the recommended treatment, if your patient is less than 5 years old, is a medium dose inhaled corticosteroid. For patients 5 to 11 years old, it's recommended a medium dose inhaled corticosteroid or a low dose inhaled corticosteroid plus a long-acting beta-2 agonist, leukotriene receptor antagonist, or theophylline. If your patient is greater than or equal to 12 years old, a medium dose inhaled corticosteroid or a low-dose inhaled corticosteroid plus a long-acting beta-2 agonist is recommended. In addition to whichever one of these fits your patient, a short-acting beta-2 agonist, as needed, should also be prescribed to your patient. For severe persistent asthma, if your patient is less than 5 years old, you should prescribe a medium dose inhaled corticosteroid plus montelukast. If your patient is older than or equal to 5 years old, you should prescribe a medium dose inhaled corticosteroid as well as a long-acting beta-2 agonist. In addition to either of those, you should prescribe a short-acting beta-2 agonist for your patient for as needed quick relief of symptoms. For severe persistent asthma, located in step 5, if your patient is less than 5 years old, it is recommended a high-dose inhaled corticosteroid in addition to montelukast. If your patient is greater than or equal to 5 years old, a high-dose inhaled corticosteroid plus a long-acting beta-2 agonist should be prescribed, as well as a short-acting beta-2 agonist for quick relief of symptoms. For severe persistent asthma, in step 6, it's recommended for patients less than 5 years old to prescribe a high-dose inhaled corticosteroid plus a long-acting beta-2 agonist or montelukast plus an oral corticosteroid. If your patient is greater than or equal to 5 years old, a high-dose inhaled corticosteroid plus a long-acting beta-2 agonist plus an oral corticosteroid is recommended. In addition to those, a short-acting beta-2 agonist should also be prescribed. Note on the bottom of the slide where it says use of a short-acting beta-2 agonist more than 2 days per week for symptom relief indicates inadequate control and need to step up the treatment. Here's a list of the long-term control meds. The anti-inflammatory agents with the inhaled corticosteroids and the oral corticosteroids. The anti-inflammatory agents, which are the mast cell stabilizer, leukotriene receptor antagonists, leukotriene synthesis inhibitor, and monoclonal antibody. The bronchodilators, which consist of long-acting beta-2 agonist, methylxanthines, and anticholinergic drugs, as well as combination therapy. Here are a list of the quick relief meds. The bronchodilators consist of short-acting beta-2 agonists, epinephrine, and oral corticosteroids, as well as the combination therapy.